Hey, Steve. If you're there, Steve, we're not sure if Alan Wolf is going to be able to attend the call or not, so maybe we'll just open it up in general.
Oh, wait, I'm sorry. What's that, Michelle?
Apologies. I've just found out from one of the PEDS Environmental Health Fellows that Alan Wolf may not be able to join the call, so we're not sure, so maybe we'll just kind of open it up and we'll see if he responds after the lead case.
Which one is that?
He wanted to say something after the lead case.
Oh, okay.
Middle-aged man.
The middle-aged man is here, he says.
Hey, buddy, how are ya?
Good, ma'am.
I was telling Michelle that, you know, take the cart to the second hole, I'll meet you there.
Perfect. And bring the needles and syringes, my friend.
Oh, my goodness. I'm sitting here with your buddy, Frank Palachuk.
Hey, Frank!
Hey, Tim. And Michelle Cantor's walking in.
Dr. Pepper?
Oh, no,
he's empty-handed at the moment.
Yeah, he's drinking nothing. He's not caffeinating currently. It's an odd scenario.
What are you following, Jerry Lakin's book?
I have bone spores, Tim.
No, there's no chocolate milk. No chocolate milk, Tim.
Okay, good.
I'd love a diet. Michelle Burns loves Diet Coke. She's from Atlanta, so there's no such thing as Dr. Pepper or Pepsi or, for that matter, beer. She just drinks Coke. So we drink only Coca-Cola here in Boston.
You know, I know that. Yeah, Michelle and I often, we share Diet Coke often.
So how are you guys? Frank, it's nice to hear your voice, my friend. So on the case I give, really, anytime you want to pipe in about historical between-the-lines stuff, would love to have it.
Except I do notice that there's a muzzle here. He says it's for me, so.
Yeah, I did tell Frank, you know, they want to get through 4 articles, because I think Frank could gobble up the hour if you let him. So I've got my Palachuk Ted Turney hand signals here in case I need to like slow it down a little.
Hey, I just want a Palachuk Turney cage match. That's what I'd like. Oh, mano on mano.
Did you hear that? Did you hear that, Steve?
Yeah. We'll set it up. We'll set it up. No problem.
I'd pay top dollar for that.
Yeah, I'd split it with you.
I'd have to argue, no offense to the people who are present or not, but if you could create like an octagon or a cage and put in 3 stations, Ted and me and Ann, I think that'd be worth some money.
Well, Ann Kranz would snap you in half like a twig, Frank. Academically and physically.
Oh my. Get in there.
Hey, Steve, we might go ahead and go on mute because I'm just going to show Tim a couple of things about the.
Yeah, I know all the other people are listening now, so pre-welcome everyone. All right, so we'll mute out. We'll talk to you at the top of the hour.
Thank you. Bye.
All right, bye.
We're on, Steve.
All right, are you guys, let's see, we got people logging in. You guys want to kick it into gear?
Sure.
All right, great. And I believe, let me just double check that we're being recorded. Sandra, you hit record already?
Yep, I did.
All right, perfect. All right, well then let's go for it. All right, well, welcome everyone for another exciting edition of ACMT National Journal Club. Just going over some ground rules. If you would like to make a comment, please raise your hand. And again, after each article is presented, we really would like folks to weigh in with some comments. In addition, if you're out there on the Twitter, please use the hashtag ACMTNJC, ACMT National Journal Club, NJC, and we'll see if we get some conversation going there as well. And I would like to thank Michelle Burns, Tim Erickson, Rebecca Brucaleri, and Tak Chiba for doing this, and this is my favorite title in a long time, Toxicus Maximus Pediatric Edition. So with that, why don't you guys take it away?
Good afternoon, Steve. Thank you so much for the invitation to speak today. I am joined by Takeo Shiba, otherwise known as Tak, who is our first-year fellow from Japan, and then my lovely colleagues, Tim Erickson, who is based at the Brigham, Rebecca Brucaleri, who is based both here at Children's and within our PASU, and I myself am also based here at the Boston Children's. We wanted to point out two pediatric photos of some famous toxicologists. The photo on the left is a young Sean Bryant lifting his Maximus weight. And the photo on the right, if anyone can get to that, it's a lovely Michelle Bruja as a young child.
That's awesome.
In all seriousness, our thoughts are with the healthcare providers, victims of the hurricanes of both Houston and throughout Florida, as well as just a moment to remember 9/11 yesterday. Our thoughts are certainly with all those healthcare providers in New York City, Washington, D.C., as well as Pennsylvania. Our articles to review today are some of our favorite pediatric articles that we have been involved with over the years. The first will be a severe iron poisoning, which was treated with intermittent infusions of defuroxamine, which will be presented by Tak Shiba. The second of which is a very interesting acute lead encephalopathy case out of Chicago. And Tim Erickson will be presenting that one. I will talk about the acute arsenic poisoning in two siblings. And lastly, Rebecca Brucaleri will talk about severe carbamazepine overdoses.
Okay. Hi, this is Tak Chiba, toxicology fellow in Boston. So first article I'm going to go over is massive iron overdose case reported to clinical toxicology in 1995. Okay, so the case is 22-month-old male presented to a local emergency department 2 hours after ingested iron pills. Parents found him with empty bottle of ferrous sulfate, 300 milligram. Estimated amount of ingestion is 50 tablets. Parents were not taking it seriously because it's just supplements. And they brought him in after they found him vomiting blood. So initially his vital sign was normal, but he was pale and he was poorly responsive. An X-ray showed 30 intact tablets in stomach. They tried gastric lavage, which got only 2 tablets out. And he was transferred to tertiary care emergency department. There, he had tachycardia and tachypnea, and he was clinically in shock, although his blood pressure was normal. He had cool extremities and then unresponsive. An NG tube is putting out some blood, and he had a femoral, arterial, and venous lines, had a normal saline, and then sodium bicarb was studied for acidosis. Dopamine was also studied for shock, and defuroxamine studied at the standard dose, 15 milligram per K per hour. And his urine turned red-orange. So here, His initial iron level at 5 hours after the injection came back 16,706 microgram per deciliter. Huge injection, and so he had a Swan-Ganz catheter placed, and the fluoxamine dose was increased to 25 milligrams per kilogram per hour for this massive amount of overdose. But due to the concern for side effects such as ARDS and infection, the dose regimen was 12 hours on and 12 hours off. It continued on for 3 days. He developed a DIC treated with plasma. Interestingly, 20 hours after the injection, he looked more stable with normal vital signs. He was asking for food. But on the following day, as we expect, he got worse. Perfusion got worse, his respiratory symptoms got worse, pulmonary capillary wedge pressure went up to 20, and he was intubated. His lab also showed a liver failure. His bilirubin went up to 14.8, and ALT went up to 2,800. This is a summarizing chart of his clinical course. An x-axis showed time after the injection, and a y-axis showed the serum iron level. And on the bottom, there is a summary of clinical symptoms and the complications he had during hospital stay. He had a typical iron overdose course, started with GI symptoms, metabolic acidosis, and silent phase, followed by liver toxicity and shock. And his hospital course was also complicated with ARDS. And later, he developed a gastric outlet obstruction. So he stayed in the hospital for about 4 months and then discharged with intact immunologic function. So this is the case. So authors also listed 4 cases with a massive iron overdose. And then 16,000 is the highest number we can see on the table. Here's a quick overview of iron. Atomic number is 26, molecular weight 55.8, and then its essential nutrient. It has unique capacity. It can be both a ferric iron and a ferrous iron. It can be both electron donor and acceptor. Normal serum concentration is between 80 and 180. Then this is normal iron absorption. Usually happens mainly happens in duodenum. After the absorption, it can stay in as ferritin, or it can go to plasma with transferrin. But in overdose settings, these normal regulation doesn't work, and iron causes reactive oxygen species and through the Fenton reaction. And this damage to GI epithelium causes more iron to get into systemic circulation. And in the tissues, iron disrupts the mitochondrial oxidative phosphorylation and causes more acidosis. And direct cardiac toxicity is also observed in a case series and then also animal models. It can contribute to more acidosis and shock. So here's a quick question. How much elemental iron in ferrous sulfate? The choices are A, 12%, B, 20%, C, 33%, and D, 98%. Okay. So the actual answer is B. Ferrous sulfate contains 20% of elemental iron. So typical classical mnemonics for this is FSG 357. That is how we can remember this. And this is classical, typical iron poisoning cause. So stage 1, they always start with GI upset within 30 minutes to 6 hours. If the patient doesn't develop any symptoms within 6 hours, severe iron toxicity is unlikely. Then patient get into latent period, which is followed by severe shock, metabolic acidosis, hepatic failure in stage 3 and 4. Although it's not very common, patient can develop bowel structures and obstruction in 2 to 8 weeks. Toxic amount of elemental iron injection starts at 20 milligram per K, and severe toxicity can happen after above 60 milligram per K. X-ray also can be helpful if we can see iron fragment on X-ray. So on the left slide, left picture, there's iron pills, a beaker in the stomach. And then middle one showed after gastric lavage, there's not much change. And the third one, after the EGD removal of iron pill, there's nothing we can see on the X-ray. Also, serum iron level help us understand how severe the toxicity is. If level is between 300 and 500, GI toxicity and a modest systemic toxicity can develop. And then if level is more than 1,000, and significant mortality and morbidity can happen. Level usually peaks between 2 to 6 hours, so we typically get the iron level at 4 hours. This is a very nice chart from Goldflank about the management of acute iron toxicity. On the left side, if patient ingests only like a minimal amount of iron, and if patient doesn't have any symptoms for 6 to 8 hours, they can be medically cleared. And then if iron level is high, the amount of ingested iron is high enough, and then if patient is developing a GI toxicity, then we check the 4 hours iron level. If the level is higher than 500 microgram per deciliter, then we do deferoxamine to treat the poisoning. If patient is already developing systemic toxicity with shock, acidosis, then regardless of the level, we treat with deferoxamine. Mainstream of the treatment is gastric lavage and whole bowel irrigation and deferoxamine. But historically, we used to use ipecac and oral deferoxamine, and then we also use the TIBC to manage the patient's plan, but we don't typically use it anymore. Another quick question. Which antidote should be used for iron overdose? Some of these come back later in the case series. So left top is dimercaprol, BAL, and right top is Persian blue, and then left bottom is calcium disodium EDTA, and the right bottom is the answer for this question, deferoxamine. So 100 milligram of deferoxamine chelates only 8.5 milligram ferric iron. Indication of the treatment is severe systemic toxicity or iron level more than 500. Usually start at the 15 milligram per kilogram per hour. That's the standard dose, and we usually start at lower dose to monitor hypotension. And then we continue it until clinical resolution or urine and also urine color back to normal. And speaking of urine color, these characteristic of iron poison patient treated with deferoxamine. On the right side, these are a couple of samples from iron poison patient. One is from Chicago on the top, and bottom, right bottom is from Goldflank. This table nicely describes the trend of the iron poison in pediatric population. In 1991, we had 11 pediatric fatalities in the United States. Since then, we are making progress, and after 1997, we see clear decline. What happened in 1997 is FDA started warning labels for iron formula, and also they initiated blister packing for iron pills contains more than 30 milligrams of elemental iron. Unfortunately, in 2003, this packing requirement was withheld after a lawsuit claiming iron is supplement, not the medication. So currently, iron tablet contains more than 250 milligrams of elemental iron, need child-resistant packaging. It's interesting to review what is child-resistant. So to call it child-resistant, they need to go through a couple of test steps. So first, they collected 50 children from age between 42 and 51 months old. They gave them a bottle and then have them play with for 5 minutes without any instruction. If more than 15% of the kids can open the bottle, they fail. It fails the test. Once they pass first step, they go to the second step. They give kids instruction how to open the bottle, and then also they tell the kids it's okay to use the teeth and mouth if they happen to use it, and then give them 5 more minutes. If they cannot open within 5 more minutes, then it passed the test. It also needs to be easy enough for adults to open. So one thing I want to stress is that child resistance is not child-proof. It's only safe for 5 minutes for 80 to 85% of population. Right, that's the end of the case. Any questions?
All right, so again, if anyone would like to ask a question, raise your hand. I think that this is an absolutely fascinating case report, and I remember there was a lot building up to it. I know that Dr. Tenenbein's observation that the development of ARDS with prolonged treatment really led to the consideration of doing this in staggered doses. I guess Michelle, Tim, anyone else, are you aware of other published cases that showed success of that staggering protocol since that?
No, not none.
And we do have Fred Henrighting on the line, I believe, Steve from CHOP, so we'll see if he has any other comments, since he was certainly mentioned in this case report or case presentation.
Yeah, I'm not getting it. Is that Fred that's on the line?
Yeah, Steve, this is Tim Erickson. I'm hoping Fred's on the line to comment, because clearly he's a giant in the field and was involved in a couple of the cases that Talk referred to, and Talk, really nice job with the presentation. In case Fred is on, we'll get him in, Steve, whenever we can. And also, I do want to know if the vent rosé urine color change picture from Chicago is actually taken by Steve and I on my bedroom carpeting in Chicago. So I remember that shot from, 1992. There was a child that had a level of, an iron level of about 1,500. Steve, if you recall that.
Yeah, the PICU here at the old Children's Hospital, and it was a great illustration. I think those tubes were across 16 hours from the beginning of deferoxamine till it cleared out.
Right, and on the background of that slide, it's Berber carpeting. I just had the shag carpeting tore out of my house, so that was brand new carpeting behind that slide background. That was just
classy,
FYI.
classy stuff.
All right, so the second article, again, for those who don't know me, I'm Tim Erickson. It's really great to be here. Thanks for the opportunity. Steve and company for allowing the Boston group to do this. We are really excited about not only pediatric toxicology and its importance, but the title of Toxicus Magnus. And we wanted to highlight some besides iron. We really wanted to look into a lead poison case. And this particular one has a lot of classic Chicago authors on it, and we'll love to pull their expertise in. And after I present the case, I believe Alan Wolf of Harvard and Boston is also on the line, and he is a guru in lead poisoning, and I'd love to hear Alan's input, as well as Frank Palachek, who's the senior author on this case, which is aggressive approach to the treatment of acute lead encephalopathy with an extraordinarily high concentration of lead. And as you can see, Frank is the senior author. The first author, Robert A. Gordon, at the time was a PharmD, a poison control specialist. And actually, Rob went on to do an emergency medicine, internal medicine residency program, followed by a cardiology fellowship. So one of those eternal students, and really a bright person. And amongst the authors as well, Robert H. Williams, a dear friend, pathologist, lab guru, who would often do toxic levels for us of anything at any hour of the night back in the day where you really didn't have send-out labs. So shout out to Bob Williams, who I believe is in Florida these days, and hopefully he's okay with Irma and others moving in to his area. So lead poisoning is an introduction we know well. I could spend the whole hour on it and beyond, but we'll try to pinpoint how it applies to this case. It's still a significant problem not only in the U.S., and we know that because of the Flint, Michigan cases and the water contamination, but worldwide. It's a huge problem, particularly in low-resource settings in urban areas where we're not measuring it from a public health advancement. And buildings in the United States constructed before 1978, 1977 were exempt from prohibiting lead-based paint. And some of the acts that have changed since the 1990s, that's become a little more ironclad. But still, even if you cover the paint of these buildings, they'll peel. And if they're in ill repair and you're in urban squalor, it's a little tough to maintain these, and because of that, there's lead dust, dirt, leaded pipes, and in those individuals renovating homes in higher rent districts, there's a risk of lead poisoning as well. So it really goes after all socioeconomic status. Everyone's at risk, but certainly more in the low-income and urban housing area. So this case, and there you see is a nice picture of Frank Palachek, who I know is listening in. Frank is a hero of mine in toxicology and a great example of how medical toxicologists and clinical toxicologists, how medicine, pharmacy, and PharmD, MD, DO come together and really form an extraordinary tox team. Worked with Frank for many years, and that is not the picture of the patient. That's actually Frank. So a 3-year-old girl presented with progressively worsening visual acuity, difficulty in walking and speaking, abdominal pain, and vomiting. And for those that are listening on the phone and don't see the slides, I'll quickly read through it, and not to insult the intelligence of those reading it. But previously, this child was admitted to an outside hospital emergency department with nonspecific abdominal pain and vomiting, and was noted to be dehydrated and anemic. Because of that, she was given IV fluids and ferrous sulfate supplements, which Talk has already covered the iron, so I won't go into that. As the case progressed after that ED visit, she became more lethargic, had an unsteady gait, and her mother, who was actually a really good, meaningful mom who was really concerned about her child, noted a deviation of her left eye and a lack of hand-eye coordination. So she was transferred to the University Hospital, which was our University Hospital in Chicago at UIC. I was actually the EM physician working that night and recall her, but wasn't aware of really what was brewing in this child. And you can see her vitals. She was afebrile. Her pulse, interestingly, she's dehydrated and anemic, and yet her pulse is 60. So that's right there a concern. She shouldn't be bradycardic. Her blood pressure is 95/30. Her Glasgow Coma scale is 8. And just to cut to the chase, her hemoglobin 7.7, white count at 12, even checked ammonia levels and some liver transaminases, which were normal. The CT head was normal, and because of the concern of lethargy, even without a fever, this child was given a dose of ceftriaxone. And then some x-rays came back in a skeletal survey, and you can see these are featured in the case report, and you can see the lead lines at the metaphyseal plates or the growth arrests, which are definitely a clue. And rarely seen, it's always asked, often asked on exams, but rarely seen on the blood smear. Yes, there was basophilic stippling, and that is, although always considered pathognomonic for lead poisoning, it does appear in other entities, and it's really not that common. The KUB of the child showed lead paint chips. At least that was suspected, and of course a lead level is being sent, but that is cooking. And at the time, and when Frank comments, he can tell me his recollection of the case. It was one of those where it wasn't a rapid turnaround, and it may have even been a send-out at that time. So I know Steve Axe loves questions in these journal clubs, so here you go, Steve, and this is for anyone. Hands-on buzzers. A 2-year-old presents with this radiograph. Which of the following is the most appropriate intervention? Is it A, administer 2 to 4 mL per kg per day of magnesium citrate orally, the sparkling laxative? B, administer 0.01 milligrams per kg of IV push naloxone, because this child could be a body packer. C, initiate deferoxamine, since you now know about iron poisoning, and at 15 mg per kg per day IV push, keeping in mind Milt Tenenbaum's concerns. D, administer polyethylene glycol solution orally at 25 ml per kg per hour, famously go lightly, medical misnomer. And then E, give 1 gram per kg of oral activated charcoal. What do you want to do out there? For those of you who answered D delta, that is correct in this scenario. So really get to the chase here. I had some spin art coming at you, and I understand some of the transmission doesn't spin and grow, and particularly with our Quebec listeners. But just to cut to the chase, the blood lead level on this child was 550 micrograms per deciliter, which is definitely qualifies as maximus. This was huge, and at the time, and there was a thorough lead search done by the authors, and this was the highest lead level reported. There may have been one by Chisholm et al. In the Pediatric Journal in 1968. And to this day, and I've done a lead search, I haven't found a higher level. Those on the phone and on the line may comment if they know of a higher level. But this clearly was shocking, and why the lead level took so time to come back, because they had to keep diluting. And teaching point is oftentimes these high levels won't come back expeditiously, and if they're diluting it, it's always suspicion for a very, very high level. And you can see even a picture of Steve Axe here, Venomous Maximus, which is my new name for you, Steve.
Thanks, buddy.
As a superhero. Even Incredible Hulk had to fight Maximus, so this is got a little historic leaning, and I love the Gladiator movie. And Cutus Maximus. Anyway, back to the case. Mother denied that the child had ingested lead paint chips or lead-containing products. She did say they lived in a rather run-down urban apartment building, not very well maintained, and she was working a couple of jobs, had multiple children, had a tough time getting them for clinic care, and even their immunizations were not up to date. And a lot of blame, I remember, got put on the mom on this case, and it just wasn't the case. She was a good mom, just given a bad hand in a tough way, in a tough urban environment. So, of course, toxicology was consulted, and the whole team got on, including our PharmDs extraordinaire. And because of the exceptionally high concentrations of lead in this child, it was decided to attempt drug chelation, as well as whole bowel irrigation, as we discussed in the question. And I'd asked the group to kind of consider what chelation therapy would you recommend for this child. And at the time, it was interesting, things like succimer were just coming into being, and of course, the traditional chelators were out there. And it's not what would you choose, how would you stagger it, would you do them all at once, would you just do 1, 2, 3? So that's what made this case very, very interesting and intriguing, and I'd be interested in people's feedback. So in the case, 4 milligrams per kg of BAL was instituted, IM, for Q4 hours times 5 days. Calcium EDTA was started at 50 milligrams per kg per day, IV, times 4 days. And by the way, when I initially did these slides, I was just given a dose, and Michelle Burns, the lovely and talented toxicologist, Poison Center Director, Fellowship Director, reminded me that in pediatric cases we put milligrams per kg. So I am reforming my ways. So the whole bowel irrigation with polyethylene glycol was given at 20 mLs per kg per hour via NG tube until the radiograph cleared of paint chips. And Frank made comment on this. It went on for 3 days, and the child did not get more dehydrated. There was no electrolyte shifts. And as well, oral succimer was initiated after whole bowel irrigation at 200 mg TID for a total of 20 days. And you can see the child's reaction there in the picture. That would be my reaction. And then some. So this is I really like this, and I credit the authors with this visual, this graph, which shows on the x-axis, or excuse me, the y-axis, the lead concentration, which you can see was extraordinary, maximus high at 550. And then you see on the x-axis the therapies and the time. You can see whole bowel being initiated at the beginning, along with intravenous BAL, the calcium EDTA through the days, and then the long duration of oral succimer. And as we'll discuss, calcium EDTA does deplete some of the essential metals from you, so zinc therapy was initiated near the end. And at the end of the long stay of this 3-week stay for this poor child, her lead level came down to 69, which was quite extraordinary to get it to this, because as you know, lead is really tough, particularly if there's chronic exposure because of the 3 departments and organ systems. It hits bone, brain, and blood. So just to kind of finish up this case, we know about the exposures from 2 children from lead, and it's not just paint chips, it's toys, and for the fellows on the line, make sure you know the lead pathway and how lead affects heme synthesis. This may be, just maybe on an in-service or board exam, but this is a very important, and it makes sense when you see the havoc that lead causes on the hemopoietic system as well as CNS. And in this child, she had encephalopathy. I'm amazed she wasn't more encephalopathic. She actually walked into the ED that night, which is just extraordinary to her stamina. But know also, fellows, that BAL is not only indicated, but it has adverse side effects, painful injections, contraindications. If you have a peanut oil allergy, be careful. And again, calcium EDTA binds other metals, not just zinc, but copper and manganese. Manganese madness with that Parkinsonian gait. And if untreated, lead encephalopathy can be deadly, 60%, and there's TB, good old number 82. So the Illinois Department of Public Health inspected the home and found lead paint containing 10% lead base. Interesting, the mom wasn't forthright with the rest of the children because I think she thought Department of Family and Services may take away her children, and wasn't forthright with other kids being in the home. She finally admitted there was a younger sister there as well. She was brought in, and her lead level was 77, not as high as the other, and she was treated also with chelation therapy and did very well. It came down to 9. So pediatric considerations, of course, children are more susceptible, higher risk of exposure, more long-term neurologic cognitive impairment. We know this well. And the most important treatment is not chelation. It's not whole bowel irrigation. It's removal of the child from the source and make sure the environment's cleaned up. And with that, I want to stop and get either Alan Wolf or Frank Palachek's input on this most fascinating Magnus case. Thank you.
Okay, so we can try to, actually I've got Frank Palachek sitting right next to me. Frank, did you have any comments from author perspective?
Well, I guess the only thing I would probably, a couple small real quick things. It was hard to get the lab to agree to run the lead level because it was a Friday afternoon, and they didn't call it the stat level. And the other thing was the basophilic stippling that we found. It took the head of pediatric hematology a good 10 minutes to find a basophilic stippled red cell. So I think it's safe to say that it's still a difficult thing and rarely seen.
Oh, wait, hang on. Okay, hang on one second. Are you at the chat? I've got Fred Henredig on the line. So actually, Fred, can you go ahead? I think we're getting too much feedback. Actually, hang on, Fred. Let me see if I can fix the technology. And Alan Wolf, are you out there? Can you hear us?
Can you hear me?
Yeah, go ahead, Alan.
Sure. It's a fascinating case, and I'm not sure, Tim, but you know, some of the tragedy over in Zamfara in Africa of kids and adults in mining practices who had extraordinarily high lead levels. They may have even surpassed this, but I believe about 100 or 150 of those children died from lead poisoning, and that was just recently in the last 4 or 5 years. But this is an extraordinary case. It's a wonderful save in terms of what should be a life-threatening level of lead. And I just have a couple of things to observe. One is we're very wary in terms of parents' reports of their kids that they haven't observed them eating paint chips. You know, in toddlers, it doesn't matter how closely you supervise them in the ED, the default is always to get a KUB and look for radiodensities, whatever the parent report, if we're seriously considering lead poisoning. We you know, the whole effort of choosing wisely, we no longer recommend long bone films for monitoring the chronicity of lead poisoning and changes at the metaphysis. We use the protoporphyrins, the blood zinc-chelated protoporphyrin or free erythrocyte protoporphyrin. And if those are elevated, related to that porphyrin synthesis diagram that you showed, Tim, if those are elevated, that means there's enough lead in chronic intoxication to interfere with the ferroketolase enzyme, which is taking place in reticulocytes, leading to mature hemoglobin, and we can gauge the chronicity of the poisoning by the elevation in the ZPP or the FEP. And then the last point I'd make is, I'm not sure about your experience, Frank, but our nurses out on the ward won't administer BAL. It's too much of a problem-prone medication. You see fluctuations in blood pressure, you see local reactions, you can see, you know, anaphylaxis and so forth. So we've just had 2 cases of children's, and we admitted them to the MICU for their BAL administration simply because it necessitates such close cardiovascular and neurologic monitoring.
All right, great. Thank you. Thanks so much for those comments. And I have Fred Henredig on the line. Fred, can you speak by your regular phone? I've unmuted you on the WebEx system.
Hi, Steve. Can you hear me?
Yeah, perfect. I've just set up the cell. Go for it. Thank you.
Well, I'm sorry about the old school communications here. I just can't seem to figure out how to make our computer system hear me to communicate to you, but appreciate comments and invitations to speak. Starting with the lead case, the most recent one, I certainly echo Alan's remarks. I think there's a lot to be learned from this case. Those patients that were being treated in Nigeria recently, just to add to that a little bit, because I reviewed that very recently for our chapter in Gold Tranks, that those kids had levels, as Alan said, in the many hundreds of micrograms per deciliter, and it was a huge cohort of kids with lead encephalopathy, probably among the largest ever reported. And because of the, remote circumstances in which they were being treated, they were all treated with oral succimer alone, which is a fascinating aspect of the situation they were in. And actually, the vast majority of them had very dramatic improvement. So I don't think anyone would recommend that in a resource-rich environment like the United States or the UK or Europe and so forth. But they did show that it was possible to save many, many children's lives just with succimer therapy, often administered by nasogastric tube in the encephalopathic patients. Just flipping that around, though, I would point out that in this case, they did comment that when they stopped the BAL and EDTA transiently and just had the kid on succimer alone, the lead level actually rose a little bit. And so I think there is some, concern to be gleaned from that about if there's residual lead in the GI tract and you're using an enteral chelating agent only, I think there's some risk of actually increasing blood lead levels. The kids in Nigeria, I think it's a little less clear exactly how they were exposed. It wasn't to lead paint, it was from artisanal gold mining, and I think in that case a lot of it was probably some lead particulate matter that they were ingesting, but also inhaling a lot of by pulmonary absorption, from their parents sort of refining gold out of gold ore over stoves in their home. Well, I'll pause there. That's enough to say. I hope that came through a little bit.
Yeah, no, thanks, Fred. Actually, it is really fascinating. And one of the things I think is so interesting about this case is when do you consider the parenteral and oral combination? Frank, did you have any last comments about that?
I don't think we have the data that would let us know whether we're mobilizing lead from the GI tract with the succimer or we're just failing to give enough succimer to chelate in the GI tract. That's all.
All right. Okay. You guys packed a ton of awesome information in here. I'll turn it back over to you folks in Boston. And I don't know, Michelle, do you want to go for both articles? Do you want to finish up with one more? We have a little discussion.
Well, let me go ahead and present the arsenic two siblings, and then we'll see where we're at, and we'll see if we can squeeze in a few facts from Rebecca on carbamazepine.
Perfect.
So
okay.
without a moment of time wasted, this was a lovely summer day in New England in August 2003 when a lovely family of four went to a cookout at one of the dad's clients' homes. This client is a financial planner in his 70s. Mom asked for a bottle of water so that she could mix the formula for her 4-month-old son. He would set approximately 2 to 3 ounces of the water and formula. And then the 2-year-old sister was drinking from a cup, spit out the water almost immediately, saying that it tasted bad. And the host stated that he had lots of Vermont spring water stored in his basement. He and his wife would drive up there to drink this lovely pure water. Within 10 minutes, both children were vomiting. And so they were taken to a local emergency department about 30 minutes north of Boston. The 4-month-old little boy had bloody emesis en route. Intravenous fluids were commenced, and the Poison Control Center was contacted. And for the fellows out there, what would be your top 3 differential? In the interest of time, our Poison Center specialists stated they would be concerned about metals, caustics, and isopropyl alcohol. And you can see from this picture here, this is an actual picture of the contaminated water bottle here on the right. At the time this picture was taken, it was 21 hours post-ingestion. It was a bluish purple at that time, although it had been a brilliant purple right after the water and formula were mixed together. Once the nurse at the outside hospital had torn off the label of this supposedly Vermont spring water, it was found to be an arsenical product based out of Chicago.
No.
It was arsenic trioxide, 40% by volume and 23% by weight. And so arsenic is atomic number 33. Its molecular weight is about 75. Remember, there is a non-toxic form of arsenic, that is arsenobutane, which is trace amounts in all of us, including marine organisms. And then the inorganic forms include highly toxic types, including those that are found in the Earth's crust. Trivalent is arsenite 3+, and then the pentavalent is the arsenate 5+. Do note that these water-soluble salts are absorbed rapidly. They're almost 100% bioavailable. And then just a mention of arsenic trioxide, which is known as by the trade name Trisonox, which can be used to treat acute polymyelocytic leukemia. And so thinking about this in terms of toxicus maximus, how much arsenic was ingested? The compound was sent off to our Massachusetts State Laboratory. For patient 1, the 4-month-old little boy, he was thought to have ingested up to 428 milligrams per kilogram of body weight, while patient number 2, the 2-year-old little girl, was thought to have ingested approximately 14.6 milligrams per kilogram of arsenic. And per Jake Simmons' lovely paper from 2002, it's thought that the minimal lethal dose in humans is 1.43 milligrams per kilogram. And so the patient was transferred to Boston Children's. He became comatose en route. He was intubated on arrival by one of my very dear friends. A central line was placed. Volume resuscitation was commenced, as well as dopamine for hypotension. We brought out the British anti-lewisite in this case as well. And for the fellows out there, we can oftentimes think of BAL as for bad arsenic and lead cases, as we've just described previously, as well as with this case. A dose of 5 per kilo was used IM for Q4 hours. Unfortunately, in hour 6, as people became fixed and dilated, a severe metabolic acidosis and DIC was noted. And in this ridiculously busy slide, which is from our table 1, you'll see some of the highlighted labs there, including transaminases that rose to the 13 to 1800 range, a sodium of 164, potassium dropped to 2, the hemoglobin was down to 17, was placed at 41, the white count was 15, the pH was noted to be 702, and certainly was noted to be in DIC with a fibrinogen of 58, and the INR was 12.89. And so for the fellows, what are the cardiac complications of arsenic ingestions? What's the most likely, a PR interval prolongation, QRS, or QTC? And I know you've all read the paper, so you know the answer is QTC, and our patient unfortunately did go in and out of torsades-like rhythms, the first time being at hour number 11. And so PALS algorithms were implemented, including use of lidocaine, magnesium, beryllium, and defibrillation. He was emergently cannulated at hour number 12. He had been in uric from 2 hours past those ingestion until the time he was cannulated, had an incredible ongoing capillary leak. His admission weight was 8 kilos, and at autopsy he was 36 kilos. Hemodialysis was employed as well as exchange transfusion. We did continue the BAL Q4 hours, and then our lovely colleagues in New Sweden, Maine, who had had a similar arsenic in the coffee exposure in May of 2003, were fortunate enough to allow us to use some DNPS. A urinary arsenic peaked at spot urine at 9,000 micrograms per liter, and unfortunately supportive measures were stopped at 36 hours. The 2-year-old sister, she fortunately did well. She was tachycardic initially in the 130s to 180s. She was treated with BAL, some fluid resuscitation. Her longest QTC was 527. Transitioned to DMSA on day number 4. Her serial urine arsenic concentrations from days 2 to 13, I'll show you on the next slide. Her neuroexam was normal. We still send her a birthday card every year, and she just turned 16 in May. And looking at her urinary arsenic excretion, you can see here it wasn't until 6 weeks out that she actually had a 0 concentration of arsenic in her urine. And so the toxicus maximus number for this particular patient in her urinary arsenic concentration was 4,920. Our goal is to be as close to 0 as possible, of course. And so just one shout out for all the ACMT crew on the phone is this wonderful review by Michael Kosnet, The Role of Chelation in the Treatment of Arsenic and Mercury Poisoning. I highly recommend it if you haven't had a chance to read it yet. It was published in JMT in 2013. From a pathophysiology perspective, this is just looking at the trivalent arsenic form here, and you can see here with the blockage from going from pyrate to acetyl-CoA that there certainly is some biochemical processes which are certainly inhibited, and the binding of acetyl-CoA production for entry into the Krebs cycle is stopped. Looking at the pentavalent form, you can see it going down this pathway here where hydrolysis yields a really decreased energy when this one arseno-3 phosphoglycerate is formed, and there essentially is an effective cellular energy storage. And so this is certainly an important slide perhaps for the fellows, just to remember to differentiate between acute and chronic arsenic toxicity with all of the nausea and vomiting, the pulmonary edema, and QTc changes, certainly as well as the neurological changes in renal failure. From a chronic perspective, making sure to remember the renal insufficiency, the hyperkeratosis and hyperpigmentation. A picture here out of Bangladesh found on Google of arsenicosis, of that raindrop appearance on the skin. And from an oncology perspective, just not to forget that in the sun-exposed areas, you may have patients with squamous cell and or basal cell carcinomas. And so with our pediatric considerations, just to remember how vulnerable all of our pediatric patients are, but particularly the infant who is unable to spit out this horrible tasting water. Fortunately, from a pediatric cardiac perspective, they can tolerate large volumes of resuscitation. And a reminder what all of our poison center educators are promoting about being up and away with both our medicinals and chemicals. And so perhaps in the interest of time, Steve, does it make sense to try to get through the carbamazepine and then maybe take 3 minutes of questions at the end?
Sure, that sounds great. That is an amazing case report. What jumps out to me is having chemical products in food or drink containers. Lesson learned over and over again. But yeah, do you want to bust through the last one, and then we'll open up for more questions.
All right, sounds great. Hello, everyone. My name is Dr. Rebecca Briccolari, and I'm going to share a case of a carbamazepine overdose with you. So as we know, carbamazepine is an anticonvulsant that's a sodium channel blocker as well as an anticholinergic. And I'm going to describe a patient case for you that I had when I was a fellow. I was the fellow on when this case came in and was very involved in her care. So she's a 15-year-old adolescent girl. She was found by her parents confused with an empty bottle of carbamazepine tablets. There's up to 285 of them. She was brought to an outside hospital, intubated, given activated charcoal, and her initial carbamazepine level was greater than assay. And of note, this was her mother's medication. So she was then transferred to a tertiary referral hospital. She was hypotensive, started on norepinephrine. She had some QTc prolongation, but no QRS prolongation. She initially had some motor response, but then had decerebrate posturing, no brainstem reflexes, and fixed and dilated pupils. And her EEG showed that she developed something called stimulus-induced rhythmic periodic or ictal discharges, which we'll get to in a little bit. And she had some tonic-clonic seizures as well. So the significant lab data, what I really want to point out about this is the arterialization of her venous blood, which is showing impaired electron transport chain. She had an initial carbamazepine concentration of 86 micrograms per ml, and her extended tox screens were only significant for midazolam and lorazepam, which she was given in healthcare. So for our toxicus maximus concentration, approximately 13 hours after ingestion of carbamazepine, was 138 micrograms per ml. And so the next slide shows a graph of the time after ingestion with her carbamazepine level, and then the different interventions we did to manage this patient. And the thing I want to point out to all of you is that if you look when we gave intralipid, you can see an increase in her carbamazepine level, and that happens on the first and second doses of the intralipid infusion. So we used multiple techniques to manage this patient. The first I want to talk about is gastrointestinal elimination. She got 1 dose of activated charcoal at the outside hospital. She had an endoscopy where we removed 22 tablets and about 150 tablets passed in her stool. The reason we didn't give her multi-dose activated charcoal is that she had developed an ileus. We had also tried whole bowel irrigation with Go Lightly. That was also not successful due to her ileus, and that's why we wanted to do an endoscopy. We actually had also even asked surgery to come take a look at her to consider actually doing an axillap to remove tablets, but at the time, because her level started to decrease, surgery had signed off. So we also used a couple of techniques for enhanced elimination. One of them was plasmapheresis, and we replaced her plasma volume. We did a 1.5 plasma volume exchange with 5% albumin. And the reason we did this is that we wanted to bind to the lipid-bound carbamazepine as well as the protein-bound drug. And then this was followed by intermittent high-flux hemodialysis and continued veno-venous hemodiafiltration. So in the interest of time, I want to talk quickly about intralipid. So carbamazepine is lipophilic. It's structurally similar to tricyclic antidepressants and also cardiotoxic. And so that's the reason that we had tried it, in addition to the fact that she was critically ill, and we had seen success with using it in tricyclic antidepressant poisoning. And interestingly, as we mentioned before, her level increased after the intralipid doses 1 and 2, which might speak to one of the theories of intralipid working, which is the lipid sink theory. The other interesting thing we had done was we put her into a pentobarbital coma with the idea of decreasing her metabolic demand. And the thought of this was we noticed that she had impaired mitochondrial function as she had a rising lactate. We continued this once her lactate decreased to 3.7, and then she had a venous oxygen saturation that was 83%. Another thought was that because we could induce their CYP453A4 enzymes, that we might assist her in carbamazepine clearance. So she ended up doing very well. She got her brainstem reflexes back on day 4. She ended up getting finally extubated on day 10, and she was discharged 2 weeks later to a psychiatric facility where she was apparently had done well. And then briefly, we talked about mitochondrial dysfunction, and we did a study with the metabolite of carbamazepine and showed that it can hyperpolarize the mitochondrial membrane potential, and this is associated with prolonged complex 1 inhibition. And then for pediatric considerations, this case showed a case of SIRPs, which we have only seen in case reports for children. And for the fellows out there, which false positive would you expect from a carbamazepine overdose? And the answer would be tricyclic antidepressants. And so I'd like to turn this over to Dr. Michelle Burns.
We just wanted to thank everyone for joining us. And then, Steve, do you want to take over and ask questions from the overall audience?
Yeah, no, that sounds great. So anyone out there that would like to ask a question, please raise your hand. We will acknowledge you. And while I'm waiting for some hands, you know, that's just such a fascinating case. I mean, what a heroic job you guys did to get such a good outcome. Looking back at it retrospectively, would you remove any of those interventions, or would you still do all of them again?
I think actually, and when I took a look at this case again and went through some of the basic literature behind everything that we've done, I think I would do everything the same way.
Okay, great. And I'm not seeing any hands. Actually, while we have all these great pediatric minds on board, we have a local case. Actually, Teresa Kim, one of our senior fellows, a quick question.
Hi, everyone. Okay, so we recently got a case. It was a 2-year-old who came in with a lead exposure. The level was 49. And the child has just been intolerant of Sexamer. So the kid was admitted to see, you know, for social concerns as well as to see if we could get the child to tolerate Sexamer. And after, you know, a long weekend of struggling with this kid, he's tried everything from applesauce to juice to, you know, sweets that we've tried to hide it in. And long story short, there's been no success in getting the child to tolerate Sexamer. And so the last resort has been the question of if we should just put an NG tube in the kid and send him home and have mom administer Sexamer through an NG tube, which of course has its own risk in a 2-year-old who also has a twin, you know, who the two of them can just be a lot of trouble together. And so I don't know if you guys had any tricks up your sleeve of how you've gotten, you know, these pediatric cases to tolerate Sexamer in these difficult circumstances.
Hi. Go ahead. This is Alan Wolf. I just appreciate the difficulties. You know, that's the problem with Sexamer or Chemid, is that it's not kid-friendly. It's difficult to achieve compliance, and it's one of the risks when we send kids with lead poisoning home. our first priority is to make sure the home is lead safe, that it's hazard free with respect to lead. We don't want them continuing to ingest lead. We try to work with parents around DMSA. If they're in-house, parental EDTA is the way to go.
Okay, great. Any other thoughts? If not, no, thank you, Alan. That's great. And we are definitely at the top of the hour, and I think we might as well wrap it up. Michelle, Tim, did you folks have any last-minute comments you wanted to make?
Yeah, just with the summary slide, Steve and company and all listening in. So when you have a massive or maximus overdose, it's not your typical PDR pharmacokinetics, as we know. It shifts to toxicokinetics and things behave differently. Massive overdoses may equal multiple antidotes. Sometimes you do have to throw the kitchen sink at them, but you don't want to do it to the tune of adding too many other toxins to the mix, because as we know, the antidotes have side effects as well and are poisons in themselves, but oftentimes you got to pull out a couple. Rapid diagnosis improves chances of recovery. You really have to be at one with your lab, and the lab may be diluting and sending out, and it may take a little heroic measures of helping them out, making those connections in the middle of the night in particular. Fatal outcome may be unavoidable, as in a couple of the cases, the tragic arsenic case that Michelle described. Despite the heroism that was done, unfortunately, that child was lost. And working knowledge of chelators is essential, not only for your boards, but for taking care of these patients. But hopefully you enjoyed this, and we want to thank not only the Massachusetts, but the Rhode Island Poison Center. Dr. Stephen Elliott Axe, thanks for hosting. As always, you do a tremendous job involving everyone and really covering some terrific topics. And, of course, ACMT. And let the lava light flow for everyone, and go ahead and take a hit off a mushroom on my account. And with that, I think we're done in Boston, unless Michelle has any closing comments.
Yeah, thanks so much for joining us, and we look forward to seeing everyone in Vancouver.
All right, and yeah, I can't thank you all so much, Tak, Rebecca, Tim Toxboy Erickson, and Michelle. That was fantastic. Fred Henretic and Ellen Wolf and Frank Palachek, thank you for joining us as well. Our next edition will be November 14th, the Portland group. And yes, we're looking forward to seeing everyone in Vancouver. With that, we'll sign off, and thanks so much, everybody.
Thank you, Steve.